All right. Hello, guys. Rafael here. Today I'm going to be talking about a very interesting trial that I found. It was published in 2021 in the Lancet Oncology, and it is titled The Maintenance with Daratumumab or Observation Following Treatment with Bortezomib, Thalidomide, and Dexamethasone, with or without daratumumab and autologous stem cell transplant in patients with newly diagnosed multiple myeloma. It was known as the Cassiopeia trial. It was an open label randomized phase 3 trial. Okay, so let me explain just a little bit what this trial was about. First of all, it was conducted in several medical centers in Europe, or all throughout Europe. And it basically consisted of two parts. So the trial was divided into two parts. The first part of the trial was like an active treatment of the disease, and then the second part of the trial was more of a maintenance treatment. So the first part of the trial wanted to compare two treatment options. So the standard of care at the time for multiple myeloma in patients with stem cell transplantation was bortezomib, thalidomide, and dexamethasone. So one of the intervention in groups in the trial received only the standard of care and not the new drug, which is daratumumab. The other treatment group received alongside these three drugs also received daratumumab. And basically what they wanted to see was if the inclusion of this new drug helped a patient improve their outcomes in this disease. Just for a little bit of context, daratumumab is a monoclonal antibody that binds to CD38 receptors in both plasma cells and erythrocytes. And once it's bound to these cells, it can be attacked by immune or it can lead to an activation of the immune response. And in this case, they can attack and destroy these plasma cells that cause, or multiple myeloma cells that cause the events are associated with disease. Okay, so they showed that the group with daratumumab had improved the depth response and progression-free survival with an acceptable safety. So once they got those results, they didn't want to stop there. They wanted to see if daratumumab was also effective um, after the initial treatment of the disease. So once the patients still in the study who had had a partial response or better were assigned to the part two of the Cassiopeia trial. This second part was a maintenance treatment and it was divided into two treatment arms, one of which was daratumumab 16 milligrams per kilogram, IV every 8 weeks, and the other group was only observed, so it received observation only. And then the participants were followed for up to 2 years to see if this new drug helped them have less progression or had more progression for survival or less progression of the disease. Okay, so yeah, just for the method section, and this trial or this manuscript talks about this second part of the trial, so the maintenance of the disease. And for the primary endpoint, they decided to measure progression-free survival, which is a time to event data, so they did a survival analysis. And for the secondary endpoints, they had time to progression from second randomization. They also had proportion of patients who had complete response or better. They also measured the overall response rate, the overall survival, and the safety. Okay, so for the statistical analysis, just to mention, the alternative hypothesis in this case was that daratumumab maintenance improved progression-free survival compared to observation only. That's what they wanted to test. And they did an intention to treat analysis. Every patient that was assigned to either of the treatment groups was analyzed during the study. They did sort of a sample size calculation where to achieve 80% power with an alpha of 0.05, 390 PFS events were needed, but they also pre-planned an interim analysis at 281 PFS events, and the results, that they got for this manuscript or for this paper were at this interim analysis, and we'll see how this affected these results later on in the slides. Okay, so for the choice of the statistical test, they wanted to, we know that it was a progression-free survival, so it was time to event data. How did they measure this, or how did they show us this data? For the distribution per treatment group, they used a Kaplan-Meier estimator. To compare both treatment groups, they used a stratified log rank test. We know that the log rank test is the statistical test that can tell us if there's statistically significant difference between two groups um, who are who have time to event data or survival analysis data. So yeah, they did a stratified log rank test. They stratified by the type of induction and the depth of response. But the thing is, the log rank test only tells us if there's a difference, but it doesn't tell us how much difference there is between the two groups. And for this reason, and to get the treatment effect or the hazard ratio, they used a Cox regression model to tell us what the hazard ratio was. However, you know that the Cox regression model can tell us, can be helpful to adjust for covariates. However, in their case, they only used the maintenance treatment, so either daratumumab or observation as the explanatory variable. They didn't really adjust for any covariates. And lastly, they also did a subgroup analysis and a forest plot, which I'll show in just a bit. These are the main results. Basically, they got 886 patients, 442 were under daratumumab, 444 observation only. The median number of administrations of daratumumab was 14, and the median duration of treatment was around 24 months and 24.2. And at the right here, these are the baseline characteristic of both of the groups, and I would say they were fairly balanced. There wasn't really much of a difference between the two groups in these regards. Okay, so here we have the Kaplan-Meier estimator. We can see that there are two curves, a red curve and a blue curve. The red one corresponds to treatment with daratumumab. The blue one corresponds to the observation only. And then at the y-axis, we have the progression-free survival percentage of patients, and at the x-axis, the time since second randomization. Sorry. So we can see that just by looking at these curves, we can see that there's a difference between the two. Looks like the daratumumab group had better progression-free survival compared to the observation-only group. And this is also measured when they did this is the results of the Cox regression model. They saw that there was a hazard ratio of 0.53 with a very significant p-value of less than 0.01. And basically what this tells us is that daratumumab had better progression-free survival, so better outcomes compared to the observation-only group. And this is also shown by the downward spiraling curve in the sense of the observation-only group, and when the daratumumab group had less of a step down. I also wanted to mention that here we can see that the numbers at risk or patients that were at risk of the disease. And what I found striking about this is that if you start looking at it, there's a very few patients who were censored, the ones in under parentheses. But after the 24-month cutoff, which was their initial time that they wanted to evaluate them for, you can start to see that the censored observations start to rise significantly. There's 112 to 164, 201. And I think what happened here is that not every patient was followed for 27 months or 30 months or 33 months just by the nature of their trial. Not every patient is assigned at the same time. Not every patient is followed for the same amount of time. And perhaps this meant that there wasn't really much like a completeness of follow-up for every single patient. But I think overall, despite this, we can see that there's a very significant difference between the two groups. Okay, then we have the findings. So at the pre-planned interim analysis, so 281 events, the median follow-up was 35.4 months. So we see that not every patient was followed for the same time. And then the median progression-free survival was not reached for the daratumumab group. So we didn't really get 50% of the patients who had progression-free survival events in the daratumumab group. It was reached for the observation-only group. It was around 46.7 months, but we didn't really have the upper end of this spectrum. And I think this happened because there wasn't really enough time for follow-up. Probably this outcome requires a much longer observation, but I understand that they wanted to do an interim analysis and they wanted to see how the data looked at this stage. And as I mentioned before, they got a hazard ratio of 0.53, showing that the daratumumab group had a better progression-free survival compared to the observation-only group. And there were 108 PFS events in the daratumumab group versus 173 in the observation-only group, so much more, or many, many more events in this second group. For the subgroup analysis, they the subgroup analysis by sex, age, sites, staging, among other things, induction, minimal residual disease and response. And overall, we can see that in most cases, it looks they had negative hazard ratio, less than one hazard ratios, which favor the daratumumab group, showing that it looks like the daratumumab is effective in most of the subgroups, which is a very positive finding. Although there's this special one that wasn't really significant or was around one. Um, okay. So I wanted to see if they tested for the assumptions. We know that the Cox or most statistical tests require testing for assumptions, although we know that the Cox regression model isn't really a parametric test. It still has some things that it needs to meet, some conditions that it needs to meet. So on the one hand, uninformative censoring, which basically means that the patients who end up being censored from the analysis are censored not because of the nature of the intervention or the nature of the study design, but rather you don't want that to happen. You don't want to lose patients because of the nature of your study design, or you don't want to see that patients are being censored because of your study design. I would, although this is difficult to see because you don't really have data for each patient or for every patient in the study, I consider that censoring because most of the patients were fortunately followed up, and those that weren't or that were censored were not so because of like adverse events or things like that, or it doesn't look like that. It looks like they were more not followed up because there wasn't really enough time to follow them up, all of them up. So yeah, I think this assumption was mostly met. For the length and completeness of follow-up, perhaps this is a point of contention because you couldn't really follow up all the patients for the required amount of time, and the completeness of follow-up wasn't perfect for each of the groups. But I understand that they wanted to do an interim analysis. They wanted to see how it looked like, and the results are very significant, showing that one of the groups is significantly better than the other one. So perhaps we can understand their decision to do their analysis at this time. For the linearity between the covariates and the log hazard, well, in this case, they didn't really include any covariates in the analysis, so it wasn't really um, necessary to think too much about this assumption. And lastly, for the proportional hazards assumption, which basically implies that the hazard ratio measuring the effect of any predictor is constant over time, they did this log plots to evaluate it, and we can see that it looks to be proportional. So there it looks in both of the treatment groups, the proportion of survival probability compared to the time of follow-up is relatively similar, and the two curves don't overlap at any time. So they consider that the proportional hazards assumption was met at this stage. Okay, so just to finish up, a discussion about the strengths of the study. The results were significant. Daratumumab every 8 weeks for 2 years significantly reduced the risk for disease progression or death compared to observation only, so that's good. I would consider that they had a good choice of statistical tests. We saw that it was time to event data, survival analysis, so they did a log rank test, Kaplan-Meier estimator, and then a Cox regression model. I would consider that in this case, it was a good choice of statistical tests. It addresses a research gap because they mentioned that there was little evidence previously about this topic, about the maintenance with this drug. And they also had positive results in almost all subgroups. So it looks like the overall treatment effect in most patients looks to be good. But as in every study, it also had limitations. For example, the follow-up length, like it should have been longer, in my opinion. There was a lot of data that we didn't really get. I understand that the trial is still going on as I'm speaking, and they're still collecting data. So perhaps we'll get results or better results later on. Yeah, I think that this was for at least for me in the analysis, it was a main point of contention. Observation rather, okay, so they had for the comparator that did observation only rather than lenalidomide, which is now or what in Europe is considered now the standard of care. And I think and they explained that this happened because when they started to do the trial, so around 2015, when Cassiopeia started, lenalidomide was still not approved as maintenance for multiple myeloma. So perhaps if you wanted to conduct this trial now, it wouldn't be ethically possible to use observation as the comparator. You would have to do lenalidomide. So yeah, I think this is also another limitation, but I think they address it pretty well in the text. Also, the final duration of the maintenance period. This is another thing because at the time when they designed the Cassiopeia trial, patients were only treated for a finite amount of time. But now, the overarching paradigm is that you treat patients until progression and not until not for a set amount of time. So if you wanted also to design a new trial, you would treat patients indefinitely until they progressed or not. So this is another limitation, but this is, I would say it's not their fault. It's just what the standard of care was at the beginning of the trial. And lastly, the use of dosing every 8 weeks. Now it looks like daratumumab is even more effective if you use it every 4 weeks. But this is also because at the time, 8 weeks was what was known to, or what was considered to be the better option. Now it looks like if you wanted to conduct this trial now, you would have to do it every 4 weeks. So yeah, thank you so much. This was a lot, but it was a very interesting trial, and thank you for your time and for your consideration. Thank you.